go on to the Q&A session. But before we do, there's a poll that I think that we can put up. Can we get that put up here, Val? To get a general sense of what people do. The question here is, how often do you perform laminoplasty in your practice? So go ahead and vote and submit, and we'll do the results of this poll shortly. Before we get there, I wanted to go over the Q&As for people that have been asking from the audience, and we have a question from Simon Chang, and this one is to Howard. He wants to know about your experience or comments regarding oblique. Hold on one second. Looks like we have the results of the poll. So how often do you perform laminoplasty? None is 23%. Seldom is almost 40%. Often is 30%, and many is 9%. So obviously it's the minority, and we can kind of discuss this during the Q&A session as well. So thank you for voting. So Howard, back to the question regarding oblique corpectomy in patients with cervical myelopathy. Are there advantages and disadvantages of oblique corpectomies, and how do you perform those, Howard?
That's a good question. There are many ways to do a corpectomy. Oblique technique is not something I do. When I do corpectomy, I do a traditional corpectomy where, you do a discectomy first, and obviously you follow with the corpectomy at the intervening. But to be honest with you, when I started, I did a lot of corpectomies, but like a couple of years into it, I've been doing this for 30 years. You think that there are 3-level involvement, so you have to do like 2 or 3 corpectomy, but at least one disc is not as bad as the other disc. So what I often do anteriorly is that I do a corpectomy at one level and discectomy another level. So I try to do that as much as I can, so I can put what I call sort of quasi-segmental fixation. So you put 6 screws instead of top and bottom. Then I don't have to do posterior approach. So anterior alone. In fact, we published that biomechanical construct on hybrid construct to be reasonably stable that you don't have to do posterior. So I do some cases you have to do a 3-level corpectomy and you have to do a posterior augmentation. But if you do a hybrid corpectomy and discectomy, anterior alone fixation is enough.
Great. Thanks, Howard. We have another poll, actually. This one's from Dr. Esther Kim. For multi-level cervical disease, would you perform? The first option is multi-level ACDF. Number 2 is anterior hybrid. Number 3 is laminectomy and fusion posteriorly. And number 4 is laminoplasty. So what is your preferred, let's say for a 3-level disease, 3-level cervical disease with myelopathy, what would you perform?
Jeff, I just wanted to make a comment about C5 palsy because Hyung brought it up, and I think it's a good comment. A couple things with C5 palsy. It's actually a nice paper that came out of Seattle that looked at C5 nerve translation relative to shoulder taping. We all tape the shoulders quite a bit, and I think it's very similar to bending the table for a lateral procedure or taping, where we're starting to bend the table less and stretch less and do less. And since that paper came out, I really started taping my cervical spines much less aggressively at the shoulders, both anterior and posterior. And I do think that probably significantly reduces the C5 palsy rate. The other thing is I think a prophylactic frameotomy in a setting of severe stenosis posteriorly to avoid a C5 palsy is a good thing. But since doing that and avoiding taping, I've actually rarely seen a C5 palsy. I think the taping is a big deal.
You think a lot of it's traction based?
I think a lot of it's traction based during positioning.
Yeah, and I think for that matter, like doing a laminoplasty versus a laminectomy. In a laminoplasty, you can kind of control the posterior drift.
Sure.
And so I when I'm doing posterior approaches, I kind of hate laminectomies now. I almost want to do a laminoplasty infusion because I want to control the posterior drift. And even in my laminoplasties, I don't really try to go crazy with lifting the canal. You know what I'm saying? I mean, I'm pretty well controlled these days. I try to put a 6, maybe 8, but I'm not trying to shift the canal dramatically because a little goes a long way.
So
The
look at this.
laminoplasty procedure is actually so much harder technically in my mind than the laminectomy fusion.
Yes, agreed.
Laminectomy fusion to me is like a super quick thing, but it took me a while to learn different tricks for the plasty. That is a really technically difficult procedure. It sucks you don't get paid for it really to do it, but it's a hard procedure.
So before we go on, these results, poll results, are really interesting in light of what we just recently saw. The minority saying that they would do laminoplasty, but when you take a look, when you drill down on what we would do specifically, procedural-wise, for multi-level cervical disease, would you perform which one? And the minority said multi-level ACDF. A third said anterior hybrid. About a third said laminectomy infusion, and a third said laminoplasty. You know, which is really, really interesting. So, sort of back to you, Brian, on the question of, and Hyun brought this up, but how do you perform? Hey, Brian, are you paying attention?
I'm always paying attention.
One of the panelists like tweeting, or I don't know.
I'm checking my Yelp reviews. I'm checking my Yelp reviews.
This is the world of Zoom today, man.
Fine. I'm entering ones right now.
I'm actually seeing a patient right next to me.
No problem at all. I know we're running a little bit behind. Hey, in any event, the question that Hyun had for you, Brian, was like, how do you perform laminal foraminotomies on the hinge side of your laminoplasties?
I still do it. Sometimes the lamina cracks because by that time you just don't have enough lamina. And I think it's very difficult, frankly, to plate that side. So I've always, if it's an intervening segment, I've just left it floating. It's not been a problem. But, you know, usually cross my fingers, I'll just go on the side where I'm opening. The hinge side is tough. You almost always expect that lamina to crack, but I've actually not had issues with cracked lamina as an intervening segment.
So a follow-up question, is it possible to do bilateral foraminotomies and laminoplasties, which you just answered? This. Second question is, have you ever done laminoplasty and fusion, and what are the indications?
I haven't done that. I know Dan Rue kind of talks about that to limit posterior drift. I think there is value in that. I don't know of any papers that compare the laminoplasty fusion versus just the fusion. There are really good papers looking at trough width and posterior cord drift, looking at outcomes in C5 palsy. I forget who makes the plates. I want to say it's Globus, maybe Hyung, you know, where you can put the lateral mass screw through the laminoplasty lateral mass side. So I haven't done it, but I've seen it done. I think, you know, I haven't seen the outcomes comparing the two, so it's hard to say.
Yeah, I'd say I like the idea. I've done it probably a handful of times, and I don't know who makes the plates. It's usually just trying to find room for a little lateral mass plate between your lateral mass screws. At the end, I just find it when you do it, it's just a more elegant procedure. You know, you don't have the cord exposed. You don't have to worry about, you know, having some trauma to the cord. You know, once I see it, it always reminds me that I actually like this procedure. But a lot of times, you know, technically it's very difficult. We've got fellows, so you know, it's, you know, sometimes you just want to get in and get out, and you know, you feel like it's pointless doing all this work. But I think if there was a good way of trying to preserve the lamina and give you that canal space and then do a fusion, I do see some benefit. I don't like the cord just drifting posteriorly without any control.
So a question to Howard regarding how you stage procedures. You mentioned that for patients with fused facets, how would you stage that from anterior to posterior in order to actually get the releases that you need and the correction of the deformity?
Yeah, when I say stage, I mean, I usually do it in one day, but whether you do a posterior first, you know, anterior first, that's what I mean. So whenever you do an anterior osteotomy, like the case I showed you, you gotta really look at the CAT scan very carefully, because, you know, after like 10 years or whatever, the facet may be spontaneously fused. Then you won't be able to crack it. So if the facet is, you know, not fused, then you know, after anterior osteotomy, it'll crack and you can, but if it's completely fused, you want to do a posterior, you know, facet release, and then anterior, it becomes a PAP, which is a rare case, but sometimes you do that, you know, but in general, in terms of just a related comment about the staging is that sometimes I combine laminoplasty with the anterior procedure. Like if you have like 99% canal compromise, patients are severely myelopathic, particularly if you have some calcification OPLL, you don't want to go anteriorly for fear of, patient become quadriplegic. You can do a laminoplasty first and let the cord drift posteriorly. And then when you do 1 or 2 level anterior, discectomy or, decompression, the procedure becomes very safe. So remember some cases that you can do laminoplasty first, and then you do a anterior procedure. Now, one question about the laminoplasty with the fusion, it doesn't make sense to me to do a laminoplasty of the entire, 3 or 4 level and fusing the entire segment. I mean, that's what Dan talks about, but it doesn't make sense to me. Either do a motion preservation, motion. However, I have combined, say you do 3 to 7, laminoplasty, but maybe 4 or 5 for some reason has a spondylolisthesis or whatever. You want to do a 1 level fusion, and you do a laminoplasty. What you do is you put a little bone between the motion segment. Then you are doing fusion at one level. So I have combined selective fusion at 1 level with the laminoplasty, if that makes any sense.
Got it.
Yeah. Mm-hmm.
Question from Stephen Ru to Hyun. How do you get insurance approval for these hybrid techniques, multi-level hybrid techniques, including the disc replacement?
So fascinating enough, I mean, obviously, we do have people who will pay. That's one. But now, this is where I've done a lot of cases recently, and my partners is that multi-level cases usually happen in the 65-year-old and older patient. What I'm talking about is not, OPLL, confluent OPLL. I think those cases should be treated with a laminoplasty. But when you have these kind of multi-level spondylotic patients that you're like, okay, I got to fuse 2, but now I got to fuse 3. Oh my gosh, I'm fusing 3. Now I got to fuse 4. Those multi-level spondylotic patients, you can do a hybrid procedure, and now Medicare pays for it. It is crazy. They don't pay very much. But actually, at least in our kind of territory, Medicare will pay for a hybrid procedure and an artificial disc replacement. So, that's where I kind of see a lot of this. I see a lot of cases now. It's really because I'm treating multi-level disease in the 65-year-old and older population. I don't want to do a 3-level fusion. And a lot of times I feel like I'm forced. Like if it's a 1-level, 2-level fusion, I may just do that. But as soon as it becomes like, oh, I'm fusing 2, but something doesn't look good, I've got to fuse this one. And as soon as I get into that scenario, I really choose to do a hybrid procedure or even a multi-level cervical arthroplasty if they have good bone density.
So I'm going to open this up to all of the panelists to try to answer some of these questions here. But Yoo-Jung Kim has a question about how do you factor in preoperative neck pain, and does this change your position regarding anterior versus posterior? For any of the panelists.
Yeah, let me chime in on neck pain, because neck pain, because when you ask about that, the question about 3-level disease, you do ACDF, corpectomy, laminoplasty. Every procedure, I do all those 4 procedures, but every procedure has an indication. So which, for some patients, but I want to do a least operation. For me, ACDF is, the best operation if you can do it. However, ACDF may not be enough to, decompress the, retrovertebral disease. Then you have to combine with the hybrid corpectomy. So when you have a neck pain, that's one of the problem with the laminoplasty. I mean, laminoplasty, obviously there are many reasons for neck pain, whether it could be residual C4 radiculopathy, which nobody talks about, or, closure of the, and then, fixation method. There are many reasons for neck pain. However, having said that, if patient has a severe preoperative neck pain, because laminoplasty have this problem associated with, postoperative neck pain, I tend to stay away from a laminoplasty. I tend to do a posterior, laminectomy infusion for that. Now, if I have to do a bilateral myeloradiculopathy patient, bilateral foraminotomy, yes, it can be done on a hinge side foraminotomy, but for me, that patient gets bilateral decompression with a fusion rather than laminoplasty. And so for me, there are sub indication for this kind of different procedure. I select what's best for the patient.
And I think for the posterior neck pain, I mean, when I do laminoplasties, I'm a little bit more aggressive these days. I mean, a lot of people will have neck pain. When you look at the arthroplasty studies, everybody has neck pain, and the neck pain relief is almost better than the arm pain relief. So, I mean, for a laminoplasty patient, when I say, okay, when I'm talking about neck pain, I mean, they really have to have pretty significant neck pain. If they have like mild to moderate neck discomfort, and I feel like a laminoplasty is a better operation, I will certainly do that. I mean, that doesn't bother me as much these days because you close everything well. You do exactly what Brian says. You really try to avoid any type of kind of abutment of bone. You really fixate the lamina now. It's not like you're just tying it down where they can move. My laminoplasty procedures, when I'm done, I want that thing to be very rigid, meaning that I don't want to fuse a patient, but I want the arch and the attachments to be very rigid, to have very little motion. So I think that also helps with decreasing the neck pain.
So then let me ask you a question.
Sorry,
wait.
I was going to make a comment about neck pain also. Just the,
Go ahead.
I think the C3 laminectomy technique is great because you really don't have to detach C2 to get C3. But when you look at fusion versus laminoplasty, there are good papers that compare PCF to laminoplasty. And interestingly, the post-op neck pain scores in the meta-analysis and even in the side-to-side study show there's no difference in post-op neck pain. Meaning a laminectomy infusion doesn't necessarily give you less neck pain than a laminoplasty. And from my standpoint, it also has to do with what the neck pain is from. So maybe there's one really bad C3-4 inflammatory facet with a normal looking spine. But if there's no pinpoint why that person's getting neck pain preoperatively, I won't necessarily do a fusion just to try to get rid of their neck pain because the literature doesn't suggest it.
So Brian, you presented that, one of the potential reasons why we're not seeing as much laminoplasty could be like reimbursement. So let me ask the panelists then. So if it's so good, Hyun specifically, then why aren't you doing more of them?
I actually do quite a bit, but I love what Brian said is that, it's those cases where you kind of end up doing a hybrid, like a case where you have like a hot 3-4 facet, where it's, you can see it's bulging, it has osteophytes, and you want to do a posterior laminoplasty. I think those are the cases that you would just fuse the 3-4 level and then kind of laminoplasty everything else. That's kind of a hybrid. I still, it's still a benefit for me. I still think a laminoplasty is it's a lot less morbid than a laminectomy infusion with lateral mass screws. I think that is a very morbid procedure. And to really do that well, it's pretty tough because you got to do an excellent closure. And the muscles have nothing to reattach to. So your closure becomes so much more important. At least in a laminoplasty, you have bone, right? And the muscle can actually kind of scar down to the bone. So I still do it. I mean, I think as far as reimbursement, I'm not like, these are typically older patients in the Medicare population. So it's not like I think one is so much greater than the other. But, if you really think about it, that would, I love Brian's technique of doing a C3 laminectomy. Obviously, if you fused one level, you would still get the fusion code for the rest of the laminoplasty. So that may be an alternative. But, I would say probably 25 to 30%, I'm doing something like this, like C3 laminectomy, fusing at one level for a hot facet, or for some other reason, I'm doing aggressive bilateral foraotomies and I'm doing something like that. And I think, that may be it.
So we're wrapping up here, and I'd like to finish off before the top of the hour. Another question was, do you guys ever extend your laminoplasties beyond C2 and C7? Howard?
C7 I've done quite a bit. C2 I don't think I have.
Howard?
When I started laminoplasty, which was 25 years ago, I learned it from my Japanese postdoc because we won't talk. Anyway, the go-to operation was C3 to C7, and I found out early that you don't need to do a C7 laminoplasty because a lot of times there's some core compression, but it's not as severe. So what I do is what I call dome osteotomy, which is a fancy name for a little undercutting the top portion of the C7 lamina. So you're preserving the important spinous process of the C7 intact, which you can close it better. So C7 spinous process is very big for a reason you want to retain it. Likewise for C2, however, there are some cases that you have to do even C1, C2, because OPLL, whatever the reason. So I have enough cases where you have to do whatever necessary to decompress, but those are exceptional cases. Typically, instead of doing a C3 laminoplasty, I do same thing at the C3. Okay, so you do a partial decompression dome osteotomy C3. So I would say my typical laminoplasty construct is C4, C5, C6, with the plate on the opening side, doing a little bit of dome decompression at the proximal distal. that's sort of my typical, you know, laminoplasty construct.
Great. So I want to thank all the panelists and all the audience members with those excellent questions, and the rest of the faculty. This was really fantastic. And as we wrap up, Don actually had to start clinic, so I appreciate all those of you who are in clinic and in surgery taking some time off in order to actually devote to educating the rest of us as well. First of all, thank you for our sponsors. Again, we would not be able to do this without your support, so we really thank you so much for all the support that you've given us. And I think on behalf of CAS, we also want to tell you all that tomorrow's session will start at noon Pacific Standard Time, 2 p.m. Central Standard Time, 3 p.m. Eastern Standard Time, and 4 a.m. Korean Standard Time. So thank you to the Korean members that we have here. I don't know who set up the schedule, but like it's pretty painful for the Korean audience, but we thank you guys. And I see Harrison and Luke were both on the call today, or on the session today as well. So tomorrow we're going to be talking about spinal deformity as well as MIS. So it's going to be a really, really good session. Don't forget to get your CME credits by visiting the CAS website at casmd.org to claim your CME, and the password is CAS2020. So on behalf of everyone at CAS, we want to say thank you so much for your first session. We'll see you tomorrow, and we look forward to seeing you in person. All right. Happy 4th of July, everybody.
Bye, all.
Thank you. Bye-bye.
Thank you.
Thank you.